Thank you. Okay, so let's see. Just going to open for some questions if there are any questions, and I will double check to see how I can share my slides so you can review them. It's a lot of information. One thing that I haven't really talked about in my presentation is importance. I briefly addressed the importance of nutrition, and really, these medications are not, they are to be prescribed in addition to a comprehensive nutrition plan, as well as behavior modification and exercise. So the medication by themselves are not magic bullets. We have to first start with the foundation of weight management, which is the nutrition. Then, the behavior modification needs to be, and the mind work is very, very important. And then what is very important regarding nutrition, if there's only one thing for you guys to remember from my presentation, is that protein is very, very important. So as you all know, protein intake tends to be less than what we desire to be or we need to have. And all of this medication makes bringing in the amount of protein even more challenging. So that's why we see significant muscle mass loss on patients that use GLP-1 agonists or any medication that suppresses appetite, and they're not bringing in the minimal requirements for protein. So since weight management and obesity is a chronic condition, the treatment is chronic. So that means that if you are ready to prescribe an obesity medicine, you have to be ready to prescribe it chronically. Now, that being said, if the patient has side effects or if they don't lose 5% of the initial weight after 12 weeks, then you discontinue the agent and you try a different agent. But the treatment is chronic, so long-term. I tell my patients, let's use an agent and we'll stay on it if it's beneficial and it doesn't cause problems, to get you to weight loss and then to maintain 6 months. That means at the minimum 1 year of using these medications. And then after that, we can try to take you off this medication if we add more tools like exercise, behavior modification, and so forth, right? But you can pull this tool and not replace it with a different intervention because the weight will come back. How do you titrate the dose of GLP-1 agonist? Do you base it on patient's progress, weight loss, plateau, and when goal is achieved, do you lower dose or stay on the high dose? That is a very good question. So I really titrate the GLP-1 dose much, much slower than the label recommendations. So for example, I start at a low dose and I stay on that low dose for as long as the patient has benefits from it, not just 4 weeks. So for example, with medications, with the pens that have titration options, right? So for example, Saxenda has a titration option as compared to Wegovy, that's 1 dose, 1 pen. You can't really titrate the dose, right? So on the ones that have titration, I created my own kind of titration that's much, much slower than what the label recommendation is. So I believe Saxenda recommends starting with 1.2 milligrams. I always start at 0.6, and then I teach the patient what to be looking for. So I'm looking for, the appetite suppression, the fullness sensation, but not to the point that it will prevent them to eat the recommended amount of protein. So if the appetite is too suppressed, or the side effects, the nausea, the indigestions are so bad that now the patient is craving carbohydrates and is not eating protein, that is not beneficial. So whenever they feel that the side effects are impacting that minimal amount of protein, the nutrition they bring in, I ask them to reduce the dose. Whenever there's no side effects and the fullness and the appetite needs better control, I ask them to slowly increase the dose. So really, I educate the patient, I put it in their hands how to adjust it. And then we do see the patient every 3 weeks, and they can communicate with all the providers in my practice via like a HIPAA safe messaging in case they don't know what to do. So when they reach goal, so what I want you to know is that when they reach goal, they actually need this medication more than during the active weight loss. So I typically don't decrease the dose at the beginning of weight maintenance. So when I transition from active weight loss to maintenance, I try to make very slight gradual changes. And the first change that I do, I increase their caloric intake. So we add those 300 calories that we subtracted from that basal metabolic rate to see the weight loss progress. And after we add the calories, we evaluate how the hunger is controlled. Now, many times patients will tell us that they're hungry, and you have to tease out of them, is it physical? Is it emotional? Because if the hunger is emotional and they are on a GLP-1 that controls physical hunger, and you keep increasing dose of GLP-1 agonist, that is not going to be beneficial for emotional hunger. So always pause and try to ask the patient to describe what they mean that they're hungry. When in the day is the hunger a problem? When do they get in trouble, right? So they will tell you that they feel, their stomach is growling, and the distance in between meals, it's not the way it used to. They feel hungrier sooner. So that's physical hunger. So then adjusting the dose of GLP-1s will help. If it's like, what, I do good in the morning and lunch, and then I come home 3 o'clock, forget about it, it's all junk food, that's emotional. That means processing emotions, stress management, identifying that emotion, that in conjunction maybe with a medication that will help with emotional hunger, which are contrary to pyramid, right? But the behavior modification is basically the intervention. So before adjusting medication, know what component of appetite you're treating. Is it physical? Is it emotional? That's very, very important. So I got here late, so great presentation, thank you. Is there anything specific to postmenopausal weight? So postmenopausal weight is basically, in my opinion, it's significant by the way it affects your insulin resistance, right? So we lose the protective effect of the estrogen. A lot of women gain abdominal weight, and that is a clear indicator of insulin resistance. So I typically don't treat postmenopausal women any different than a patient that has insulin resistance. And I think the new medications that help decrease insulin resistance, like GLP-1 agonists, metformin, they really help well. But also understanding that as we get older, our tolerance to carbs decreases, even if we don't have signs of insulin resistance. So our basal metabolic rate decreases, our tolerance to carbs decreases. So we have to assess barriers on each patient, and kind of accept the fact that the older we get, the more barriers we have. So that means that we have to be open to adding more tools to the intervention to overcome the barriers that now we have because of aging, because of muscle mass loss that has happened over time, because of insulin resistance or leptin resistance with chronic dieting. Would you recommend staying on the lowest dose needed for ongoing weight loss before titrating up, or is the recommendation to titrate up to the maximum dose tolerated? I never go higher than the dose that's beneficial to the patient just because I can. So I always tell the patient, I want you to find a dose that will control your appetite and will allow you to eat the amount of protein that I have calculated for you. If that is half of the max dose, we stay on half of the max dose until the hunger becomes a problem. Because guess what? Once they lose another 20, 30 pounds, the hunger will become more intense, and then we will have to have room to go on that dose. So no, I don't go to the max dose, just because we can or because the patient can tolerate it. I really judge that on how the patient responds to the medication. Please talk about the importance or not of eating 3 meals a day. I'm on semaglutide for prediabetes and obesity. I'm just not hungry for breakfast most days. Should I eat something, fruit, small serving of oatmeal anyway, or wait for lunch? So my recommendation would be that when you take GLP-1 agonists, you cannot trust your signaling systems as well as just like you can't trust them sometimes when they are not functioning properly. So when you take an appetite suppressant, whether it is an old appetite suppressant like phentermine or a GLP-1 agonist, your signaling is off. I mean, that's the whole point, right? So that being said, if you're not hungry, you have to ask yourself, well, can I delay my breakfast, right? Instead of skipping a meal. So my recommendation would be not to skip a meal because it's very difficult to catch up with the amount of protein you need to bring in to support your muscle mass. But I would recommend skipping your snacks. So then instead of forcing yourself to have a breakfast. And by the way, you want to eat protein first thing in the morning. So you want to do a protein breakfast and stay away from fruit and grains first thing in the morning. So I would eat a protein late breakfast. When you feel that you can do that, it can be a protein supplement, since you're not necessarily physically hungry and you just need to start your day and boost your protein intake. And then you can bring fruits or grains later in the day. And that way your blood sugar won't be as affected, especially if you have insulin resistance, to tip you into storage. So in this case, I would recommend 3 meals a day, skipping the snacks and having a later protein breakfast. And really not trusting, having a structure and not go by appetite, because those signals are going to be affected by the medications that you're taking. Is there any treatment not meant for those that have had bariatric surgery? No. All the meds that we can use on a patient that has had bariatric surgery. The question is, what is the barrier? Is it physical? Is it emotional? Is it both? Is it decreased metabolism? What is the barrier? So the fact that the patient had bariatric surgery does not limit their choices. GLP-1 agonists are actually very, very beneficial because they give back that satiety that the patient had right after surgery. So a lot of my patients that had bariatric surgery and have regained the weight, they say, you know what, this medication makes me feel the way I felt after the surgery. Are there to get protein in, do you recommend protein shakes and supplements? Absolutely. With our lifestyle and the pace that we're living, I believe this is one that I'm having right now. There's no way for me to have my lunch and do this presentation. So I really like protein beverages that are high quality. The one I would recommend is this Fairlife Core Protein. This is 42 grams of protein. I don't have any shares in the company. I'm not promoting it, but it's just easy. And if I don't have time to have my salad for lunch and I have a presentation, a meeting, skipping that meal is not a choice for me. So then I grab my shake or protein bar, and that makes my intake of protein constant no matter how hectic my day is. So yes, I strongly recommend them, but I really recommend good quality. So do your research and find good quality one and reliable sources of protein. How do you deal with the constipation associated with semaglutide? So Very good question. So number one, slow titration. Number two, everybody that's on my program has the Senna/Docusate as a gentle, stool softener and gentle laxative that they can use at the first sign of having a hard bowel movement. I don't even want them to skip a bowel movement. As soon as they have a hard bowel movement, I recommend taking 2 of those Senna/Docusate combination. And then making sure they have enough fiber, making sure that, if the Senna/Docusate doesn't work, they go to Miralax, making sure that they drink their water, making sure that they're not eating too much cheese. There's so many components that the diet intervention can cause constipation. You all know that. And then you add an agent that can cause more constipation. So you just have to be more aggressive about that. And that's how I do it. Also, there's recent information about intermittent fasting not really working, as well as weight loss, as initially reported. Yeah, I did my talk on intermittent fasting the last time, and it really, really, intermittent fasting, it's a tool. It does work for some individuals, just like meds and diets. They don't all work for everybody. So I think the one thing to remember about intermittent fasting, like I mentioned on my talk on intermittent fasting, is to really make sure that you're bringing the amount of protein you need to keep your metabolism running and to support your muscle mass. What happens when you are at max dose of semaglutide and have lost 30 pounds and now not budging in more weight loss? Do we switch patient to Mounjaro? So I guess the question is, what is the goal, right? Is the goal to lose more weight? Is the patient at a plateau? Do we need to give them more time, or they really need to lose another 30 pounds because they have severe obesity? So if they have severe obesity and they're halfway through their journey, then consider changing the agent. But first, try to evaluate if this is a true plateau. So really make sure you ask the patient to track nutrition, do the nutrition audit, right? Because if we just jump to conclusion that, oh, the med needs to be adjusted or changed without checking our boxes, are they eating enough food? Are they eating enough protein? Are they keeping their carbs under control? Are their calories under or at goal, right? So the nutrition audit will answer a lot of those. So 3 days of tracking. Second, evaluate if we're talking about physical versus emotional hunger. This patient might not be physically hungry, so they might be struggling with emotional hunger, and they might benefit from an agent like Contrave to control emotional hunger, right? So just going to a superior GLP-1 doesn't necessarily mean that it's going to offset the barriers that they're having. So let's find out first why they're not losing weight. So now if let's say, okay, nutrition is on point. They're not eating too much. They're not eating too little. The protein intake is appropriate. The patient is physically hungry, so they're struggling to contain this, or they're not hungry. They're just stuck, right? Then it's worth going to something like Mounjaro, right? Which is, by the way, it's pending approval for weight management. So right as of today, it's not approved for weight management. It's only approved for type 2 diabetes. And Mounjaro is superior to Ozempic from a few standpoints. Number one, it does offer better glucose control, better appetite control, and improve satiety without as many GI side effects. So it's a little bit more gentle on the GI tract. And then it does affect food chatter and carb cravings and cravings for alcohol. And I hear this from my patients all the time, and there's not a mechanism described yet that I know about that explains that, but I see it on every patient that is on Mounjaro that tell me, I'm not thinking about food, I'm not craving alcohol. So it does have an emotional hunger component. So if you have somebody on a GLP-1 that is struggling with emotional hunger, you have two choices. You can go to Mounjaro if their plan will approve it, or you can add an agent that helps emotional hunger, like topiramate and Contrave. Remember, be aware, know your medication, know the side effects and the potential side effects and the contraindications. Yes, that's a really good question. I like the Quest bars. Those are the typical ones that I use, but there's Atkins bars. There's so many out there. Is there effect of weight gain if eat more than recommended amount of protein for our weight? Yeah, for sure. But it's not a common problem. It's not something that I encounter that often. So I would say, especially for women, we tend to undereat our protein. Every so often, I might have a guy that overeats his protein because maybe he has, 2 protein shakes for his snacks, and those are high in protein, and then he eats a lot of protein for meals, and that can definitely put him into storage. But everything too much will become a problem. But I would say I don't see that in women for sure. Yeah. So the challenge is always getting it close to the goal. And when I say goal, I typically recommend it by height and gender, and I give the patient a target, like for example, a simple rule of thumb, like 5 foot to 5'6", 16 ounces of protein, and then you can be within two lower, 2 upper, right? So it's like 14 to 18, the range, right? If you're a woman and you're 5'8" to 6 feet tall, we go to 18 ounces of protein, again, plus minus 2 ounces, right? So there's a range, right? So 16 is your lowest, 20 is the highest, and so forth, right? So as long as you're within 2 ounces of that medium goal for protein, your muscle mass will be protected and your metabolism will run better than, under eating a protein. Do you see barriers with insurance covering phentermine for longer than 4 months? Yes, absolutely. I don't even do prioritizations for phentermine anymore, because even if they approve it, it's only for 3 months. So I tell my patients, go get the GoodRx free coupon, $11 at, I don't know, the main pharmacies. So I don't even put that for insurance anymore. It's not worth doing the effort for that. All right, great questions. So I will find out how I can share the slides with you guys. If you guys don't have any more questions, I wish you a wonderful week, and I'll see you next time.